slides to be done. So I thought, let me talk of something which is very common. I think you are near exams, or some of you may have already given. So it may be interesting to you from exam point of view also, but that's not the primary aim. Primary aim is to make you see the point that actually from physical examination you can get some hemodynamics. So if I can move my slide. See, very often when I am, let me know if there is any issues with my presentation. Very often when we take round, I hear this, the patient was hemodynamically stable, but he died. How often you have had this feeling? And that only goes on to show that we really don't understand hemodynamics, and therefore we make such kind of errors, by the way. And I don't intend to do any spoon feeding, because I don't believe in teaching for exams. The real thing is that if I tell you, you might forget. If I teach you, you might remember. But if you are involved, then you will remember and you will really understand. But how is to involve yourself in hemodynamic assessment? And it is only by examination. Unfortunately, most of the time, you start doing this just 2 weeks or 4 weeks before exam. And then you suddenly find new syndromes, and you suddenly really find it works. The commonest thing I've seen is the residents are really surprised that actually they are able to make up diagnosis by physical examination. So it goes on to show that this is an important ritual. It is not only a ritual, it is something which is vitally important. Unfortunately, it is getting less and less because there are not enough even teachers who can really seriously teach hemodynamic or physical examination. There is a renewed interest even in the West, and when American Journal of Cardiology will tell you or JSSC will tell you, then we will start agreeing to that. There is growing evidence base for validity of physical findings, but we should know its limitations. So if you understand the limitations of physical examination, it gives you a lot of important things. The point is that eyes do not see unless the mind knows. And which of these findings do not give hemodynamic information? In cardiology, we do pulse, blood pressure, JVP, edema, weight, RV, LV, apex, parasternal heave, S1, S2, S3, murmurs, intensities. Which of these do not give hemodynamic information? In fact, all of these give nothing but hemodynamic information. So for us, everything is hemodynamics, isn't it? Provided we know and we understand and we put it in perspective. Now, how do we go about that? Let us say physical examination gives you a fair idea of hemodynamics. Accuracy only increases with experience, like any other skills. And when you really think about it, you will realize that the incremental value of other costly tests that you do, echo and MRI, etc., is limited. It doesn't give you as much information as is portrayed. Yes, it is important. We do need them. But a lot of it is also gained through physical examination. But as I said, we should know the limitation of physical examination. Now, physical examination is not synonymous with auscultation. The common error in cardiology is to think of physical examination as auscultation. In fact, when you get a case, you must, before auscultating, see the general examination and find out and think, what are you going to see? What is your question? What are you going to look for? And auscultation does not only mean murmurs. Auscultation has much more than murmurs alone. But before that, general examination illuminates central examination. So if you are okay with your periphery, if your pulse, blood pressure, JVP, then your central examination is going to only add, and it may clarify things more. But most importantly, generating a clinical context is the most important issue. Putting the finding in a scheme of things, but in history and physical examination perspective, and making a proper diagnosis, that is what is all about. You have been learning physical examination from MBBS, MD, and DM. So it's pointless to get into each and every, S1, S2, murmur, etc. Although we will touch some of them. But in the exam, from physical examination only, you are able to say the quantum of shunt, isn't it? Whether the shunt is more than 2:1. If there is a flow rumble alone, if there is a S3 alone, you say it's 1.5 to 2:1 shunt. If there is flow rumble at mitral, then the shunt is more than 2:1. Presence of PH, you say by P2, split of P2. Severity of rheumatic lesions in heart disease is all said by physical examination. And even in coronary heart disease and cardiomyopathy, which are common actual clinical patients, normal patients, the cardiac output and filling pressures are said by physical examination, isn't it? The entire Western literature, since they don't talk much about congenital and rheumatic physical examination, they all the time talks of heart failure patients, acute decompensated heart failure, chronic heart failure, how to find out congestion, how to find out cardiac output. And physical examination is real. It really gives you these things if you put your mind to it. And my idea of telling you today is to make you interested in getting physical examination done, not in passing exam, even though by knowing this, you would be able to do that also. Well, in the exam, what are you going to say? You are asked to make this assessment about severity of the lesion, mild, moderate, severe. That depends on physical examination. How do you tell about severity of PVH? There is no direct estimation of PVH. PVH is only surmised by indirect means. History of dyspnea or orthopnea means raised PVH. Increased JVP correlates with PVH in absence of other right heart disease. Severity of PVH you will tell by severity of the symptoms. pH you tell by loudness of P2. Heart failure you say by JVP. And ventricular function you should hazard a guess. So these are the things which you are supposed to say in any complete diagnosis, isn't it? And a lot of it, in fact, all of it can be surmised to a significant extent by a right proper physical examination. But what happens in the exam? Why my findings are wrong? Part of it is because of lack of training, that in last 2-3 years you never examined a patient lying down. The patient only was sitting. You really never put your mind to it. So this skill has undergone disuse atrophy. Or you really not tuned to think hard enough. This is not fitting with that. That is not fitting with this. So what is it actually? You're not thought hard enough. There are some real traps which you should be aware, and that sometimes become clear only in retrospect. So there are some specific skills which you need to understand. And there are sensitivity and specificity physical findings are not 100%. For example, if there is a heart failure, S3 is not always there. If there is orthopnea, I forgot to tell you, I need some 4 or 5 volunteers to be able to, interact. Are they there? Can you tell me if there are 3-4 people who have joined, whom I can ask and answer? Hello, anybody there?
Yes, sir.
Are there people volunteering who can be able to answer questions?
Yes, sir. I'm just giving them answer.
You can ask few people to join so that during the course they can probably interact.
Okay.
So the sensitivity, specificity or physical findings are limited in the sense. So therefore, every finding is not there every time, and you have to know the sensitivity, specificity. So therefore, there is a hierarchy of reason, which means if the P2 is loud and you are very sure P2 is loud, you can say yes, pH is very likely there. But the specificity, sensitivity of S3 in heart failure, P2 in pH, etc., are being only explored more recently. So there is a hierarchy of reasoning, So every case does not have every finding, but you should be able to synthesize the fact. The whole idea of coming to a clinical conclusion is synthesizing things. So what we call as context generation. So for example, I'll just show you a couple of examples. Since you know the basics of physical finding, I have not gone into them. We will go one by one. For example, now I want you people to react. When does a patient with mitral stenosis have RV apex? Any one of you, if you are there, you can write in chat box or you can probably answer. I think if you answer, it will be good. When does a patient with MS have RV apex? This is an example of generating a context. Patient of MS always have PH, so all of them don't have RV apex. So when the patient has severe TR, so you cannot argue that patient has PH with MS, all MS have PH, but unless there is a severe TR, so you can't have a RV apex in the absence of TR. For example, a patient of MS, you claim that, okay, this is mitral stenosis and has RV apex, but has no TR. That cannot make it. Silent MS can have a RV apex. That means the patient has severe mitral stenosis, so much so with TR that the murmur is not heard at all because the whole thing is rotated. So to diagnose silent MS, you have to have gross TR. The kind of error we make in synthesis is that patient we say have no TR and we are claiming that patient is PH and therefore there is RV apex. That doesn't work out. Another condition where patient of MS have RV apex is, now if any of you can claim, so see, this is just a session for opening your mind. It is not a session for passing exam, but in doing so you will find that several exam cases are being covered. A patient of MS in exam and has RV apex is a patient of ASD with MS. So this is what is called as a context generation. That in this case, there is an ASD and MS, patient is RV apex because of ASD, which is getting more and more flow because of MS, for example. Now, when does a patient with LV dysfunction have sustained apex? Can a patient of LV dysfunction have sustained apex? So you are finding sustained apex, there is cardiomegaly, and I am claiming that there is LV dysfunction. So which are those situations where there is a sustained apex with LV dysfunction? See, every sustained apex is not LV dysfunction, no? Anybody with hypertension, aortic stenosis has sustained apex. Hypertrophic cardiomyopathy has sustained apex. But when does a sustained apex means LV dysfunction? So since you people are not speaking and since time is limited, I will probably have to somewhat hurry up, but I hope you are with me. So when a patient of MR goes into LV dysfunction, a hyperkinetic apex of MR becomes a sustained apex. When a patient of AR who is otherwise volume overload goes into LV dysfunction, there is a sustained apex. So when the LV is a high mass and maybe high volume and that goes into dysfunction, it gets sustained apex. Does patient of coronary artery disease have sustained apex? Yes. Coronary artery disease LV dysfunction can give you sustained apex. So ordinarily one would think that sustained apex does not mean LV dysfunction, but situation with high LV mass can give you sustained apex. When does a RV have systemic pressure but no parasternal heave? Here is a right ventricle which is having systemic pressure, but it does not show parasternal heave. What is this kind of situation? As Dira rightly says, whenever the RV is decompressed, so a patient of Eisenmenger syndrome or even a patient of TOF, VST is not good enough, patient of TOF or patient of Eisenmenger syndrome, either way, does not show parasternal heave. But a patient of pulmonary stenosis, when he has an intact septum and has a systemic pressure, it is certainly going to have parasternal heave. But one would have a knowledge that a 10 to 15% of patient of pulmonary stenosis do not have parasternal heave. So these are the kind of arguments which goes on an exam when you synthesize a patient diagnosis, you see. So there is a patient with severe pulmonary stenosis who is no parasternal heave. He has gross TR. So your theoretical knowledge should be there that 10 to 15% of patient for no reason may not have parasternal heave. But ordinarily, so many times people diagnose tetralogy with parasternal heave, Eisenmenger with parasternal heave, because they do not know that when the RV is open, when there is the hole, parasternal heave does not come. Another example of generating a context. When does the ASD patient have cyanosis but no PH? There are 7 or 8 causes of patient of ASD who is blue but is not in Eisenmenger. So here is a patient of ASD in which you are getting a good flow of murmur of ASD, but patient is blue. So what do? What are the settings when a patient of ASD have a good flow murmur of ASD, which is what? A flow murmur across the pulmonary valve, a flow murmur across the tricuspid valve. So I'm telling you that the ASD patient has a more than 2:1 shunt, but has cyanosis. So there are several causes. So TAPVC may be a good answer. Eustachian valve may be redirecting the flow. This still patient is basically left to right flow, but there is something. What else? Common atrium, associated Epstein's. So there are several causes. So in a patient of ASD, cyanosis does not mean PH. So then how are we going to diagnose PH? In ASD, we say the loudness of P2 does not tell us PH, which means a patient of ASD can have a P2 which is split and heard at the apex, but it does not mean PH. So then how do we diagnose the Eisenmenger ASD? So ASD patient in Eisenmenger has no murmur. His P2 is loud and his split is narrow than before. So a narrow split which is fixed. RV apex hyperdynamic is not a part of Eisenmenger. RV apex will become less hyperdynamic. So listen to me again. A TAPVC with normal PA pressure can give you blueness. An ASD with severe PH can give you blueness. But in a TAPVC patient, you have a flow murmur. In an ASD Eisenmenger patient, you don't have a flow murmur. So a patient with cardiomegaly, no flow murmur, parasternal heave, some TR, you can say ASD Eisenmenger. So everything is possible whichever way. So you have to put it in context. That is called as context generation. Some more examples. When does a wide pulse pressure occur, but due to pulmonary regurgitation? Here is a patient who has a wide pulse pressure, but not because of AR, because of PR. Can you think of it? And these are exam situations. If somebody can speak out, it will be good, but I hope others are with me that when the patient is PDA, so PDA alone, as somebody said, is not a good answer. Pratibha, PDA alone will not do that. You have to have PD with Eisenmenger, isn't it? You have to have PD with Eisenmenger. So it's Eisenmenger PD only when there's AR will masquerade as PR, not alone PDA. So yes, that's correct. So you have to be wary of the situation that actually you are getting wide pulse pressure, but the patient seems to have a PR. When does a giant VV in JVP occur without TR? You are seeing a patient, there is a giant VV, but there is no TR. LVR shunt, that's a good idea. Tricuspid atresia doesn't make much point. No, one is LVRA shunt. Another one is there is no TR. That doesn't mean there is no murmur. There is some murmur also. So when there is a ASD with MR, so here is a patient with ASD MR, and MR is masquerading as TR. So you are finding a murmur at the apex, which looks like an MR murmur, but the patient is gross JVP. So you are able to say that must be an ASD. Okay. When do you have pulsatile liver in absence of TR? And these are just probing your mind, and just this is making you see, this is how hemodynamics are inferred from physical examination. And each physical examination can mean different things under different circumstances. Pulsatile liver in absence of TR. Shiny says TS. So AVM is a good answer, but yes, AVM is, I didn't think of AVM, but yes, you could have hepatic AVM. Obstructive TEPC doesn't give pulsations. AR can give pulsations of liver? No. Okay. So you have to see, number one is it a systolic pulsation or diastolic pulsation? I did not say it's a diastolic pulsation. It's a systolic pulsation. So this were diastolic pulsation in CCP. A patient of CCP regularly have diastolic pulsations, a little bit faint, but there is no TR in majority of them. So therefore, it is important to really think little deeper than very superficial, and then go according to the situation. So, and how will we know that is it because of CCP or because of AV malformation? AV malformation will have a wide pulse pressure. Can a patient with tamponade have hypertension? Can a patient with cardiac tamponade have hypertension? Quick. Time is at the premium. So, 1/3 of patient with cardiac tamponade in a series in NEJM, you can see that series, 1/3 patient had hypertension. Hypothyroidism does not have tamponade. Hypothyroid patient is hardly ever in tamponade, so hypothyroidism is not the right answer. But patient can get hypertensive because he's hypertensive and he's feeling very pain. So the heart under that circumstance can also raise pressure. So it is kind of, see, this kind of traps we should avoid. We should have a clarity of thought that if the patient is hypertensive, if he has a sympathetic stimulus and he's under severe pain, some body can generate high blood pressure also. So therefore, you cannot say that, no, this is not tamponade because there is hypertension. In fact, let me say it again, 1/3 of patient in emergency ward with tamponade had systemic hypertension. Means pressure is higher than 120, 130, and sometimes it was even very high. So do not exclude anything like that. So this is an example of hard data versus soft data. Can Kussmaul sign occur in DCM? You are aware of Kussmaul sign. Can it occur in DCM? How? Somebody is saying yes. So ordinarily we know Kussmaul sign occurs in what? In tamponade and in tamponade and in RCM, isn't it? So could it be part of DCM? Yes, when the DCM is severe, so you have to understand the physiology of Kussmaul. Once the filling pressures becomes too high, I mean, you are at the end of the spectrum, so then any more input is not taken. So therefore, Kussmaul sign can happen in DCM also. So this is a ringside view of how actually life goes on in real world. But before getting too much into S2, S3 split seriously, you must do a proper general examination. And before putting your steps on the chest, you have to have a thorough general examination and get a mental picture of what are you going to get in. For example, if you have seen carotid and there's a slow rise pulse and the patient is in heart failure, you know that you may probably going in for aortic stenosis. So never skip this and never skip other findings. That means other system examination before you put into heart, and then you can see. And this is a textbook scene, often one has to distinguish between a loud ejection systolic murmur and pansystolic murmur, where where you can make some clinical errors. Sometimes a loud ejection murmur and pansystolic murmur look similar. When you see systolic murmur, close the door. When you see a systolic murmur, sometimes the early systolic murmur gives you different hemodynamic information. And a common clinical question is how to distinguish PS from tetralogy, which is depicted here. The murmur of tetralogy, as the tetralogy becomes severe, murmur becomes faint. As the PS becomes severe, murmur becomes loud and crosses the S2. Murmur of hypertensive PR and normotensive PR are different. So thinking physiological is important. If you're serious auscultationist, then you must seriously pay attention to S2, because S2 holds the key to most interpretations and diagnosis. And your synthesis should be important. Two simple things which we can get out of our mind, which are direct. If you have a low pressure TR, you have different murmur, and high pressure TR have different, because TR is easy to identify. And if you have low pressure TR, you clearly know the PA pressures are normal. You know the low pressure TR is early systolic murmur, decrescendo type of a murmur. And a low pressure PR, for example, is also give you a clear idea that pulmonary pressures are normal compared to the high pressure PR, which is like a AR murmur. This is, of course, MBBS stuff. So not going to in detail, but this is a depiction of a low pressure PR. Sometimes you oscillate post-op TUF patient, you find that there is a second sound, then there is a gap. And even after a gap, there is a murmur which is crescendo, decrescendo. You know, the commonest error of PR is looking like MS murmur. It is not uncommon at all. Most of the time, to diagnose PR is MS murmur, because there is a diastolic murmur of a intensity which is moderate, which you don't normally hear. So rehearse this and compare that with high pressure PR. So high pressure PR is when going to tell you that PA pressure is high. Can you say the PA pressure by loudness of P2? We say when the P2 is loud, it is PH, but can you quantitate the P2? Yes, I think some attempt has been made, and if you can hear a P2 at the apex, then PA systolic pressure is at least 75 millimeter. So the farther you can hear a split P2, loud P2, it is higher the pressure. The conventional thinking is about 78 is PA systolic if you can hear the P2 at the apex, and that should help. But what is an exception to this? Patient of ASD can have a loud P2 even at the apex, which does not mean PH. Okay. Pulse and JVP are free implanted cardiac monitors. If you understand pulse and JVP, I think half of the job is done. Because cardiac output is nothing but heart rate and stroke volume. And you can see that by pulse. You can get a stroke volume idea by pulse. You can get filling pressures by JVP and wedge pressure. So, and from that, you can actually interpret so many things. And you can guess SVRI, PVRI, PA pressures, ejection fraction to a reasonable extent, not all the time. So in the exam, there is a common difficulty. Shall I say about LV function or not? You should try and say, although you may not be right all the time. So it depends. But I would be happy if somebody makes an attempt to say LV function seems like this or like that. So the point is that by physical examination, entire hemodynamics are able to be generally thought of. And you have been reading this pulse ever since so many days. From this, but even this doesn't go away. As we become more and more of a cardiologist person, we have to know more and more about pulse. So for example, if you see a bisvariance pulse, let us take one or two examples. You have a bisvariance pulse. Before that, okay. Tell me, can you tell blood pressure from pulse? Can you tell blood pressure from pulse? Or what is the pulse of a patient with severe blood pressure? Or severe hypertension, sorry. Patient with severe hypertension, what is the pulse like? What will be the pulse of a severely hypertensive patient? Derai says forceful. Sunny says yes, we can say by this thing. One or two more. Bounding pulse says Fruti. One more and then we might wind up. Rajguru says high volume pulse. So all the four are totally wrong. See, this is the trouble with hypertension. Because pulse pressure, what we feel is the amplitude of pulse. And it is not a severe hypertension fellow can have a small volume pulse or an intense vasoconstriction pulse or even a weak pulse. So don't make this error. There are some ways of saying that if you can press the brachial and roll up the radial and see when it appears and you can make some assessment. By experience, somebody can say that, okay, normal is pressure or a low pressure, because you can see other way around. Low pressure, less than 90, the pulse is small amplitude. That means a narrow pulse and also lasting small. So pulse is several things. Pulse has got a momentum, pulse has got a pulse pressure, pulse has got a duration. So when you say steady pulse, you appreciate that duration is also small, the momentum is also small. When you say wide pulse pressure of AR, you realize that there is a duration and amplitude. Wide pulse pressure of MR, just an impression. So pulse is a pressure wave, and the pressure wave doesn't tell pressure, so blood pressure has to be measured. No amount of pulse actually tells you blood pressure. And don't make this error that a patient with hypertension will have a forceful pulse. So therefore, Blood pressure cannot be told unless you measure it. And that is the trouble with this bloody silent killer called as hypertension. So keep this in mind. Let's coming back to small and weak pulse, bounding pulse, Bispherians pulse, alternance pulse, etc., etc. So, okay, let us focus on Bispherians pulse just as an example. What does Bispherians pulse tells you? I find it, and then each of these in an exam you are supposed to know which is felt where better. You know, Bispherians is felt better as you go to periphery. Pulses carotid, I mean, some of the anacrotic pulse are felt better when you are in the center, things like that. So what do you say when you find a Bispherians pulse? What are the inferences? You know, Bispherians is seen in three conditions: ASAR, hypertrophic cardiomyopathy, and AR alone. And one thing Bispherians tells you that the LV function is not very poor, is normal, nearly normal. That's correct. What does it tell you? How to distinguish Bispherians of ASAR from Bispherians of HCM? Bispherians of ASAR from or AR alone from Bispherians of HCM. I thought these are, mugged up questions, so you should probably be able to answer. Spike and dome derive means Bispherians. Bispherians is another name for spike and dome, sort of. HCM is two peaks in systole. Bispherians means two peaks in systole, dear. There is no Bispherians which is no two peaks in systole. So Shruti says HCM will have smaller second peak, and that's correct. So second peak is smaller in Bispherians and it is little larger in ASAR. Things like that. So these are just an examples, this entire cardiology we cannot cover in one lecture, but just an example of how interesting it is to do physical examination and to derive data from that. So that way, diachrotic pulse, obviously diachrotic notch, so these are one systole, one diastole, etc. Pulses alternance, pulses paradoxus, and you know what is what. Pulses paradoxus is seen in several conditions. And are you aware that pulses paradoxus can also be seen in patient with LV dysfunction or severe cardiogenic shock? We are all aware of pulses paradoxus in CCP, in tamponade, in CCP, also in pulmonary embolism. But not many people recognize that pulses paradoxus can also occur in hypovolemic shock and occurs in severe LV dysfunction late stages. And the two can occur together also. Pulses alternance and pulses paradoxus can occur together also. And there are whole kind of a discipline of pulses paradoxus, what and why, for some other day. And tamponade without pulses paradoxus also. So this is Bispherians and diachrotic pulse. And then you see, one has to keep reading. These are told in 80s, 100 and 1900, but a lot of new things are also coming up. And so we should be aware of new things also about the mechanism of pulses Bispherians, about mechanism of collapsing pulse. And a common trap in the exam is we say collapsing pulse. Why there is collapsing pulse in AR? And your answer is there is a diastolic regurgitation. Now the regurgitation occurs in diastole, the collapse occurs in systole. So how do you account for that? And the examiner feels very good that he has asked a question which you can't answer. So a lot of things are from new wave mechanics, that it is basically the wave physics which is answerable for that. And I think you should probably read that. A new cause of pulses Bispherians is aortic aneurysms. People have shown good cases that the reflected wave from aneurysm somehow gives you Bispherians pulse. This is just one case report. So just telling you that things never end. You can keep on changing. Okay, coming to JVP, bread and butter of cardiology. There are several variations of the theme because of these and that and that. So what do you understand by raised JVP? In the Western literature, raised JVP correlates best with what? We tend to take raised JVP as a sign of RA pressure. And yes, it does give RA pressure, but the correlation of RA pressure is with the wedge pressure. So for them, raised JVP means raised wedge pressure also. In a patient who is not having any right-sided problem, a patient of cardiomyopathy or coronary artery disease, for him a raised JVP is a good indication of congestion, and congestion means raised wedge also. So what are the correlates? A raised JVP, 10 centimeter of raised JVP, usually if you see the studies of heart failure, seriously in between the literature, you find that the JVP more than 10 correlates with the wedge pressure more than 22. And you know these patterns. And some of these we will show you probably. Okay. So what does this mean? Very obviously large V wave, isn't it? And if this patient doesn't have TR, then he will be having AST MR. And can this be a normotensive TR or a hypotensive TR? Any takers? This JVP. So JVP cannot tell you hypertensive or normotensive, isn't it? A normotensive TR also can give you, depending on the volume. It is said that a volume of about a 35 millimeter RV systolic pressure can give you pulsatile lever, which can be normotensive or hypertensive. So don't make that error that because it is too much, it must be hypertensive. That is not true. You can have a traumatic TR which gives you this pulse, which is normotensive. Interesting or no? I can't see, then it feels a little difficult. So at least one fellow should say interesting. Yes. Okay. But the other problem is about abdominal jugular test, which means in exam when your patient is not in heart failure. You see, one of the commonest fatal error in cardiology is saying the patient is not in heart failure when he is in heart failure. So what is our understanding of heart failure? What is our understanding of abdominal jugular test? If we say abdominal jugular test, there are numerous ways of doing it. But the point is, when the patient is not in obvious JVP raised, you have to do this test to say, so this is a sign of incipient heart failure. So a firm pressure on the abdomen, mid-abdomen, for about 10 seconds. How much is the pressure? About 20 millimeter of mercury if you have sphygmomanometer gauze. Pressure for 10 seconds in this study. And when you release the gauze, the JVP falls by 4 centimeters. So JVP is raised, sustained. So the keywords are sustained elevation, not 2-3 beats. Elevation for 10 seconds and falls by 4 centimeter of water or 3 millimeter of mercury. Then we say it is positive. And it correlates best with wedge pressure. And if there is the abdominal jugular test positive, then the wedge pressure is at least 18 millimeter. These are the kind of textbook knowledges which are useful for exam and which are useful for clinical practice also. It must be done when the patient is not in heart failure. Now, if his JVP is already raised, do we need to do it? Most examiners think you should not. But if you do it, that would probably mean it is even worse heart failure. There are some studies saying that in a raised JVP, if the abdominal jugular test is further positive, which means heart failure is much worse, but most people are not aware of those. So just have a rehearsal of how to do abdominal jugular test. What does it mean? And another one is the Valsalva. In a patient of organic TR, how do you assess JVP? So patient of organic TR has raised JVP. So when a patient is organic TR and the JVP is raised, he is in heart failure. Heart failure is nothing but inability to give cardiac output because of organic TR or functional TR, whatever. As long as his JVP is raised with TR, his output is suffering. So he's in heart failure. Another favorite thing is a Valsalva maneuver and how to do Valsalva for heart failure. You see, people know Valsalva for many other things, but for heart failure, Valsalva is one way described is you put a cuff pressure and raise it 15 millimeter above the systolic pressure and look for cortical sounds. In normal people, when they strain and when they release, you again see cortical sounds. But in a heart failure patient, like a square wave response, you will be hearing cortical sound all the while because when he does Valsalva, his output is not reduced because of the congestion. So this is touted as not many people do it, but I think theoretically it makes good sense to know a bedside marker of a heart failure by doing Valsalva. Bendopnea, one of the new ones, ask the patient to tie shoelaces for 30 seconds and if he gets breathless within 30 seconds, bendopnea is positive. Supposed to mean heart failure, is also positive in obesity, PAH, and certain other conditions. But generally suggests a high wedge pressure for heart failure patients. So what are the signs of elevated filling pressures? Raised JVP, edema, hepatomegaly, pleural effusions, positive test, orthopnea, bendopnea, square wave response to Valsalva. These all will indicate you raised JVP pressure. Fantastic. What are the signs of volume depletion? Orthostatic hypotension and heart rate. Very true, isn't it? The patient stands up and the heart rate and the blood pressure falls and the heart rate rises. You know his volume depleted. Now let me ask you something. Can you have an orthopneic patient who does not have CREPS? I think I'll wait till you answer because it's important. Patient has history of orthopnea, but when you examine, there are no CREPS. Possible, not possible? If possible, how or why? Anuradha says yes, but why? OSA. Dhanya says increased lymphatic, possible in cold and dry. So there are several aspects to it. So the one thing, let us get it out. Orthopnea can occur from many things. For example, bilateral diaphragmatic palsy can give you orthopnea, but that is not the context here. Here the point is that a chronic heart failure patient, because of increased lymphatic supply, is well known, isn't it? May not have CREPS all the time, but he may be orthopneic. In fact, majority of the time it is like this. And when they go into acute decomposition, yes, CREPS do come up. It's not that the CREPS are not there. So you have more orthopneic patient than CREPS patient. So these are the kind of putting things in perspective, isn't it? And knowing the literature and then making a diagnosis. So how do we say cardiac index is less than 2.2? When we see the pulse and there is proportional pulse pressure is very low. So what is proportional pulse pressure? It is the pulse pressure divided by systolic pressure. So systolic pulse pressure as the proportion of systolic pressure. When it is lower than 25%, it is suggestive of a low cardiac index, but the sensitivity specifics are limited. For example, in elderly who is a stiff aorta, you have a wide pulse pressure and he can still have low cardiac index. But a general assessment of cold extremity, anxious looking patients, cardiac achexias, things like that. So, and as we say, edema, RALS, and chest X-ray are poor prediction for chronic heart failure condition. So this is more of a Western literature. And again, if you see heart failure, but then more of patients in our OPD also are actually going to become more and more of heart failure patient. And we should be thorough with understanding of these things. So at the bedside level, a narrow pulse, 3D pulse, which is looking like, so which pulse pressure is small. So it's a small pulse and narrow pulse pressure, cold extremities. Now extremity cold is a good idea actually. An overall look of the patient. So this will suggest, but this is not highly, when you test it objectively, you find that they are not very, very sensitive. This was the study of Perlock, very old, very described as proportional pulse pressure, but he found it only in few patients. It's a small study. You have a large database from a lot of big trials of heart failure patients, and they have told what is the sensitivity specific to orthopnea, JVP, edema. And I think we must be aware of these things, because nowadays we are practicing heart failure more and more. And in exam also, you can get out by knowing these things. For example, S3 is not seen, it's a sensitivity specificity of 65%. One of the commonest mistake I have seen nowadays when you people have stopped auscultating is that you miss an S3, which is such a bad thing, because S3 gives you so much good idea. You feel so comfortable that, okay, I think the patient is what I'm thinking in heart failure. So you may not know so many things about split and click, but you should really not miss S3s, because S3, split second sound, etc. If you try a little bit, if you try 1 month, you will be master at this. Well, our breed is dying now, and you don't have many people who will probably be able to teach you S3, etc. also. But if you practice, let me tell you, S3 and basic things, cardiomegaly, type of effects, these are things not worth throwing away, because you don't have echo all the time. And even if you have echo, you're not going to do it every time, and this will help. So you can read some of these studies, large studies showing, sensitivity specificity about 60-70% of S3 in diagnosis of chronic heart failure. And you are aware of the Stevenson classification, how to say patient in heart failure who is warm and dry, cold and wet. I think you fellows are reading theory more, so you should be able to know this. And this is a good idea because it dictates therapy also. So how will we say elevated right atrial pressure? Elevated right atrial pressure we say by JVP, pedal edema, ascites. And elevated wedge pressure we say by hepatojugular reflex, orthopnea, bendopnea, and square wave response to Valsalva. And we have to try and see, whether right heart and left heart are matched. That means right is increased as much as wedge is also increased. And a good student knows that if there is a mismatch between right and left, that means more right-sided, more RA increased, wedge is not so much increased. It's more of a sign for a cardiorenal syndrome. This is upcoming knowledge, that if the heart right more is more right-sided failure than left-sided failure, more of cardiorenal syndromes. Well, let me ask you what is more clinically relevant in our setting. You find a patient who has more right heart failure than left heart failure. What are your differential diagnoses? We see clinically patient presented more with right heart failure and less right heart failure. We think of restrictive heart disease, we think of RSOV, we think of CCP. But let me remind you one thing. It's amyloid in modern medicine. Patient of amyloidosis often present with more congestive heart failure than more right-sided heart failure, and this is not often emphasized. So theoretically, if a patient is much more right-sided heart failure than left, you have some physical findings, and if your core pulmonary is of course correct. So you put it in perspective, if your theoretical base is there, that, this may be the cause. And when it works, it is really very wonderful that you have a patient who is giving you a history of right heart failure and has some ecchymotic patches around the eyes, bang, it's amyloid, and you clicked it. This is a good article which all of you should read, Clinical Assessment of Hemodynamics in Patients with Heart Failure. This is JSCC 2018. And this is an article which all of you should go through. A lot of what I've talked is from this article also. So what are the common errors in exam? Mistaking systole for diastole, mistaking RV apex for LV apex, being wrong in parasternal heave, not doing dynamic aspiration, or saying no CHF when there is CHF, and being wrong, not linking general examination to central examination, not examining lungs, and not changing even when the evidence to contrary is presented. And the common error stems from knowing the diagnosis before, so that you are doing a borrowed reasoning. You have not reasoned yourself. You've been told that this patient is ASTMS and you are not able to reason out. So don't do that. Now, a couple of examples. I don't have much time. I have a lot more things to say. So, which is the most neglected physical examination finding that gives you most useful hemodynamic information? Most neglected physical examination finding, which gives you most important hemodynamic information, and that is heart rate. You see, commonest error we forget about heart rate. Now, some examples. You have a post-PTMC patient. He's developed MR. He looks like stable. So how do you make this assessment that he's stable? Look at his heart rate. If his heart rate is 100, although he's not complaining, he's not stable. You have a patient of endocarditis AR. You are thinking whether to go for surgery or not surgery. Everything looks reasonable. He's not complaining. Look at the heart rate. You have a DCM patient has tachycardia. You want to start beta blocker. Should we start beta blocker because he's in tachycardia? 140, 130 heart rate. It may be sinus tachycardia disproportionate, or it may be secondary to first heart failure. So let us treat his heart failure and then we introduce beta blockers. So that is how you have to think about heart. Now there is a DCM patient with heart rate 140 3 times. No, 2 months ago 140, today 140, 6 months ago 140. What is it? Quick. It was a PGRT. Just simple heart rate examination. And then you can see ECG, oh my God, oh, this was PGRT. So heart rate is something which you should always pay more attention to it. Blood pressure, okay, there are 4 exercises here. Let me see if you can get this. Pressure, patient is 110/70 for supine and heart rate 84. When it gets up, the pressure drops and the heart rate goes up. What is the diagnosis? This is orthostatic hypotension. This may be volume depleted. This may be some drug related. But this tells us that the autonomic nervous system is functioning. This is not autonomic dysfunction. This is hypovolemia. Who is going to tell me the next? BP 160/100 supine. But when he gets up, the pressure is 160/105. What is the diagnosis? Pressure 160/100 supine, 160/105 on standing. Autonomic dysfunction? No. Where is the autonomic dysfunction here? After 1 minute of standing, pressures generally are same, isn't it? Most people, after 1 or 2 minutes, the pressures come and everything comes to normal. Rajguru says coarctation. Why coarctation? What has coarc to do with standing increase in pressure? So think about it. What is, we all are cardiologists and we look for essential hypertension. This is the finding of essential hypertension which you people have not got because you have not read it. How shameful. 30% of population is essential hypertension, but we do not know that a common way of identifying essential hypertension is that if they stand up, if there is a diastolic hypertension on standing, it is indicating essential hypertension. This is the way we practice hypertension. It's so much shallowness in our approach. Okay, just remember this. Next, 170, 105, heart rate 80. Now it gets up, pressure falls, but the heart rate doesn't rise much. Isn't it? So this is like autonomic dysfunction. Now the last one is a tricky one. 88/70 supine, and when it gets up, the pressure becomes better and the heart rate becomes less. So things have improved. Now this is, I just read it from somewhere, so I put it for your just a lateral thinking. I don't know whether any of you can catch it. This is very difficult. I also didn't believe it, but there is a case like that the patient has secondary MR, severe dysfunction. When he gets up, since the LV becomes preload is less, MR is less, and the pressures improve. Theoretically looks correct. So this is the way we should be able to understand and interpret and put it in practice. A couple of examples of just thinking, how are you relating physical finding in hemodynamics? Okay, patient has inferior MI and his neck veins are full. What is happening? Quick. These are like rapid fire. RVMI, okay. His thready pulse and his CV waves. So RVMI with TR. His desaturating and his RALs. His RALs and his desaturating. So there is pulmonary edema. Possibly correct, right? Now his desaturating, but there are no RALs. inferior MI, desaturation, but no RALs. And it's not a chronic heart failure, so we can't say that it is chronically lymphatic, this thing. Now, why should CHB or pressure cause desaturation? Inferior MI, desaturation without RALs. Hemodynamics from physical finding. VSR, how can VSR explain this? So there is a PFO which is opened up, so right to left shunt through PFO. That's correct, Smriti. Now there is a marked engorgement of veins and there is pulsus paradoxus, and ECG shows inferior MI. So this is tamponade. Is it because dissection posing as inferior MI? Isn't it? So there is marked engorgement, tamponade, and no pulsus paradoxus. Possibly dissection again, because in AR there may be no pulsus paradoxus with tamponade. So see how an inferior MI, how a single patient has different physical findings and different interpretations, but one has to be willing to do physical examination and then think. Okay, let's go to the next case. All right, there is an aortic stenosis patient. And how to define severity of AS? You know how to define severity of AS. If the patient is experienced pulse with AS, you know that LV function is normal and AS is not severe. It is more of AR than AS. All right, when do you have AS but no slow rate of rise? Patient has severe AS, but there's no slow rate of rise. Quick, time is running out. We will ask for 5-7 minutes more. No AR, no LV dysfunction. LV dysfunction can blunt the rate of rise further. I'm telling no AR. Severe AS, but there is no slow rise. Subvalvular and valvular cannot be distinguished by the rate of rise. Thick arteries. So what do you mean by that? Thick arteries? So it's an elderly. You see, LV dysfunction cannot give you this. LV dysfunction will not improve the rate of rise. No. So the point is, if you have an elderly patient in an AS, you don't miss this. The elderly can have significant AS, but because the aorta is, what this is called is ventricle, aorta is thickened, arteries are thickened, so therefore it shows quick rate of rise despite severe AS. So this is a typical example of AS in elderly not showing, and the elderly can have the other side also. Because of a anacrotic notch, the rate of rise may look slow even if there is no AS. So there's a sclerosis only. So both kind of error can happen in elderly. What is brachioradial delay? Brachioradial delay is written sometimes in very, very severe AS. Now, can you have systolic pressure 180 with AS? Yes, patient is severe. Just like tamponade we discussed, patient has severe hypertension. He was 200 before, and now his AS, it becomes 180 with LV dysfunction, but it's still possible. Can AS be silent? Yes, believe it or not. Can be severe AS which can have no murmur, and patient could really have severe calcific AS with LV dysfunction. What is this? Good. So this is M pattern this is typical CCP kind of a, this is not tamponade, this is CCP, because you are seeing two waves. Tamponade will not have two waves, it will only have X and no Y. These are two nice waves, and Y and X are both prominent. So this is CCP. Now in this case, what is the wedge pressure? So in CCP, because RA and LF and wedge pressure are same, by just getting RA pressure by JVP, you can tell the wedge pressure. These are two situations, AST patient and a CCP patient, where your RA directly correlates with wedge. Does RCMP have Kussmaul sign? Yes, very much so. You cannot distinguish RCMP from CCP by Kussmaul. Some people wrongly believe that RCMP does not have Kussmaul sign. In fact, as we discussed, even DCMP can have Kussmaul sign when they are very late. What is this? See, nothing is worse than a cardiologist telling patient not in heart failure when he's in such a gross heart failure. You see the earlobe. The pulsations are there in the earlobe, and my resident sometimes have missed telling that this is SVC obstruction perhaps because there is no pulse. No, I cannot see the waveforms, but the waveforms are seen. I hope you can appreciate. Grossly elevated JVP. So sometimes as people say, look at the arm veins and raise the arm veins, etc., etc. And this cannot come unless you practice looking at it. You start practicing 1-2 weeks before exam, you will make all these errors. Otherwise, this is fun and it's all very real. Artery or vein? This is vein actually in a patient with Glenn shunt whose forward flow is open. Okay, there is 10-year-old cyanotic child with cardiomegaly. If there is no structural heart disease, then there is a murmur on the lung and there is cyanosis. No structural heart disease, murmur on the lung and cyanosis. So, what is the diagnosis? Pulmonary AVM. Pulmonary AVM. Does pulmonary AVM cardiomegaly? So this is just a trailer how do hemodynamic work out. So pulmonary AV fistula can give you cyanosis, but it does not give cardiomegaly. So one has to find another cause for cardiomegaly, maybe anemia or something. So this is how things interact with each other. No? TUF physiology. Does it have cardiomegaly? You have several causes of cardiomegaly in TUF. PSV, ASD versus TUF. PS, ASD has cardiomegaly, isn't it? And you know how to distinguish the two by the type of murmurs, etc. This is typical exam situation. Many times discussed, so I will not go into this again. Eisenmenger and TUF. Does Eisenmenger have cardiomegaly? Neither Eisenmenger nor TUF have cardiomegaly. Pulmonary arteries Eisenmenger more difficult to distinguish. Eisenmenger can have cardiomegaly when they have TR and they are in RV failure, but that is a terminal event. So you cannot have a normal looking class 2 Eisenmenger with cardiomegaly unless it's an AST Eisenmenger. Now it's an AST Eisenmenger, then you have to argue accordingly. 30-year-old with wide fixed S2 and desaturation. So TAPVC, AST with other causes of, as we discussed. How to distinguish AST Eisenmenger we discussed. If there is no flow murmur, then it's Eisenmenger. If there is flow murmur, then maybe TAPVC or others. 27-year-old lady, wide fixed S2, basal thrill and tracks flow murmur. Heart rate of 100. Cardiomegaly, raised AV means heart failure. What is the diagnosis? Wide fixed S2, 27-year-old, basal thrill and tracks flow murmur. So AST is there. So what is the big deal? Now a patient of ASD at 27-year-old is not supposed to be in heart failure, isn't it? She's not in Eisenmenger because there is a basal thrill and tracks flow murmur. So if there is an AST, why there is a heart rate of 100? And why she's in heart failure? So this is a classical Luton patient. And you put your mind to each thing, it should be easy. Now there is a PDA with and without murmurs. So you know, differential cyanosis. 50% of PDA have right arm blue, which means there is no differential cyanosis. What are the causes of right arm blue in a PDA? Physical finding, hemodynamics from physical findings. Neonate with cyanosis has brisk pulse, collapsing pulse. Vein of Galen malformation. Lot of blood is going to brain, coming back through SVC and shunting from ASD, giving a cyanosis, because you don't think of the vein of Galen as a cyanotic heart disease. But diagnosis is written on the face once you have a brisk pulse. Of course, we are talking of a neonate, which is not very commonly come in your way. Now, this is another neonate, which was pH, severe pH, and something was done, the pH disappeared, and it is not structural heart disease. What could that be? This is slightly sidetracking, but just interesting. So one cause of pH in neonate which has been upcoming is a beriberi, thiamine deficiency. It's reported from India. 10-year-old recently diagnosed DCM has weak femoral pulses. Could it be COT? Unlikely, because COT will give you problem before and after. So it must be Takayasu. As renal bruise is Takayasu. Sometimes Takayasu can give heart failure even without hypertension. Last probably, 50-year-old has heart failure but no cardiomegaly. So, hypertension, diastolic heart failure, loud P2. Does diastolic heart failure give you pH? How much pH? It can give you severe pH. It can give you significant pH, just like systolic heart failure, as we discussed some other day. As renal bruit, renal artery stenosis, sustained apex. Sustained apex can come from hypertensive heart failure or from LV dysfunction, but then he would have cardiomegaly. RAS but no orthopnea, yes. No RAS but orthopnea, yes. That's what we discussed. Kussmaul we discussed. No S3 or S3. S3 is present in 50 to 70%, not always. What if you had kind stroke and pulsus alternance? These two things are seen only in heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction does not have kind stroke breathing or pulsus alternance. Just as a side light. So just give you a kind of a, hurriedly trying to entice you with the fact that hemodynamics can be really picked up from physical finding, basically trying to provoke you to do some physical examination while you are studying, not while before exam. And therefore get into the habit of doing physical examination, learning from this, thinking about it, arguing about it. In the exam, you are